Hello, everyone, and welcome to Care Answered's webinar. It's a Wednesday webinar. We are talking about Medicare. It's that time again, and there's lots of things to discuss for those who have clients or friends or themselves or family or employees or employers for that matter. So I'm going to get right into it. My name is Nicole Christensen. I'm the CEO and founder of Care Answered. We provide patient advocacy and care coordination to navigate people through the healthcare system. We get healthcare done. I'm also the author of the book From Crisis to Calm, which again is empowering our clients and all patients, as well as navigating them through accessing the best care for them and giving peace of mind to their loved ones. And today I am joined with my esteemed colleagues. We got the band back together again. If you have been with us and following us through our webinars to talk about Medicare. And these are some experts. So it's going to be a really wonderful Medicare discussion and hopefully get a lot of your questions answered. So I did a little bit of research and then I'll have my colleagues introduce themselves. So I found that the Centers for Medicare and Medicaid Services, also known as CMS, right? They say that as of March 2023, 65,748,297 people were on Medicare. And that's actually 100,000 more than were on September of 2022. So things are moving rapidly as far as enrolling into Medicare, which we kind of knew, right? Because of the baby boomers coming of age for Medicare and other things that are taking place. So the other thing that I have learned is some information from 2019 that only about 46% of enrollees examined their existing plan coverage for any changes, and less than a third compared their plan to any other Medicare plan. So hopefully nobody that's listening to this falls into that category because you're listening to us. And I hope you'll share it with your friends and neighbors and colleagues and coworkers, because there's changes that happen all the time, every year in Medicare in regard to premiums and coverage and out-of-pocket costs. And also, quite frankly, there's things that happen to us annually or sometimes more often in regard to our healthcare needs. So without further ado, let me introduce Al Anastasi, Jane O'Malley, and Stuart Small, who are Medicare brokers and many more wonderful things. I'm going to have them introduce themselves and get straight to the questions that are on our mind. So let's begin with you, Al, please, if you could introduce
Okay.
yourself.
Thank you, Nicole. Yes, I am a Medicare broker. I don't know about many other wonderful things, but we could talk about that. That's a figure discussion, if you will. So I'm a Medicare broker for about 6 years. I work with senior health plan specialists. I work out of my home office in Seaford. I handle all of Long Island, the boroughs, upstate, and I'm also licensed in 10 states at this point. So all of my business comes from referrals, and I just try to help people to get the best insurance I can.
Excellent. Jane?
Thank you, Nicole. I'm Jane O'Malley. I am also an independent representative for Medicare. I've been in the business full-time probably about 7 or 8 years, and then I did it maybe 3 or 4 years before that on a part-time basis. But I really love what I do. I'm also able to service the people in this area, Long Island, the boroughs, all of New York State. And like Al, I am certified in many, many other states. So those people that you know that are moving from New York to someplace else, chances are we're able to help them. And our job, basically, no matter who you talk to, Our job is really to find the most suitable, affordable, and comprehensive plan for each client.
Thank you. And Stuart?
Hi, I'm Stuart Small, and I got into advising Medicare about 20 years ago. I was exclusively an employee group benefits consultant, and I just actually an attorney who was a guardian for someone quite old, and said, I need help with Medicare for my client. And I said, I don't know anything about Medicare. So he said, well, I'll give you a couple of weeks, learn it, because a lot of people need help with Medicare. I know you, I trust you, and make this happen. So I thank him to this day for getting me involved in that world, because I still primarily a tremendous amount of employee group benefits, but over the last 20 years, what I noticed is the key decision makers, the owners, typically they're the ones turning 65 and they want help. And if I'm helping all their employees, I shouldn't say go on some website and figure it out on your own. So that's how I got involved in it. And I think all of us, I'm going to say it now, and probably other people are going to say it, everyone should really have an independent broker like Al and Jane or myself help them, because there's no cost to having us help you, and we can represent all the companies out there. And it's just a good idea to get some help and talk to one of us, someone like us. So I'm glad to be able to be part of this webinar and to offer my assistance. Thank you, Nicole.
Thank you, Stuart. Thank you.
I'll add one sentence to that, Nicole. I don't know if anybody gets Newsday, but Sunday there was a tiny little article about Ask the Expert. It was Medicare Open Enrollment Help. The first sentence following what Stuart just said: nobody can successfully navigate this job without assistance. Exclamation point.
Absolutely.
Yeah.
Agreed wholeheartedly. As I work with you guys with patients, clients, family members, friends, because it's convoluted and it's not necessarily clear for anyone. So let's start with, what is Medicare? Al,
All right,
start with
Nicole.
the
So
basics.
Medicare is a health insurance plan for the elderly at its basic. Okay. Um, it's a very convoluted, I would say, I can't think of the word, but it's confusing to people. All right, because they're used to getting their insurance from their employers all their life. And now they're thrown into a system where you got plan A, B, C, and D. And we'll talk about all that going on, I know. But Medicare covers, again, some 65 million people or whatever that number is, and it's growing, like you say, probably 10,000 people a day. There are various options within Medicare. There's two main options: Medicare Advantage and Original Medicare, which we'll discuss. It's a really, really big system, and it's not for the faint of heart. So, what you're saying, Jane and Stuart, is exactly true. Nobody can really, or few people can really manage to find out what they really need to know by going on to Medicare.gov or any other website and just trying to get through it themselves. They may be able to enroll themselves in a plan, but is it the right plan for the right reason? And do they know what all the options are? So this beast called Medicare, that's what gave birth to, really a whole industry of brokers that are focusing, myself, exclusively on Medicare.
Right. So, Jane, can you tell us what is, because we hear lots of alphabet, right? So could you break down for us Medicare A, B, C, and D, or at least start with A and B? Because I know it's a lot.
Yeah, well, if somebody is 65 or, are going on to Medicare, they're going to have A and B. A is the hospitalization portion. And for the most part, you are not paying a premium for that. If you have worked 40 quarters or 10 years, you qualify to have that portion, Part A, for no charge. The B portion is the medical portion. Well, let me back up just a tiny bit. On the A with your hospitalization, it also includes skilled nursing care. On the B portion, that's your medical. So that's typically those of you who are still on employer plans. You may be familiar with an 80-20. In other words, the company pays 80, you pay 20%. And that's what's happening on Part B. Medicare pays 80%, you are on the hook for 20%. So when you look at those two portions, now you've got something to try to fill the gaps. You've got to find something. So there's two ways that you can do it. You can do it on what they call a Medicare Advantage plan, which is called C. That's the C portion. And what a Medicare Advantage plan is it is a plan that is privately, the carriers are the ones who are sending or are working on this, and they're privately owned companies. But it's A, B, and D all in one unit. So there's nothing separate. You have to have A and B, your Medicare card, and D is included in the program. And oftentimes you have a little bit of extra perks in there where people are now finding out that they like dental, hearing, and vision. The Part D separate would be if you chose to stay on original Medicare, so you're A and B, then you add a separate drug plan, so D is for drugs, and then you would add a Medigap or a supplement. So that would be your other option. So there's basically two options depending on how much money you can spend, depending on what your needs are, and depending on what you want.
Great. So Stuart, thank you for that, Jane, because it is very confusing, I think, for a lot of people with the letters and the confusion between supplemental and Medicare Advantage. So you broke it down really nicely. Stuart, can you tell us when we're deciding, when somebody's coming to you or trying to figure out on themselves what is best for them, what are the things that they need to think about for themselves?
Well, everybody starts by getting the Part A and B. So that's the first thing I tell everybody is you need to enroll in Medicare Part A and B, and then you can decide amongst those two steps that Jane mentioned. So a lot of times people they think it might be a different path. So we start out in the same way. The next thing I would say to them is, in many cases, whether you stay on original Medicare, meaning the federal government pays your claims, and you add the supplement and the drug plan, that's path A, or you decide to move to a Medicare Advantage plan where a private insurance company is responsible for your claims, and you want to go that way. I think the important thing is for people to realize you're making a today decision for now. We're talking right now in the middle of October. People have from every year from October 15th through December 7th to make those kinds of changes, to go back. For instance, if you're an original Medicare and you want to move to Medicare Advantage or move the other way, this is a big time of year, the 7 weeks. So I always try to reassure people, particularly those that live in New York, that they have the freedom to go back and forth between those two worlds, because there are certain things that may seem better about one than the other. And truly, one is not better than the other. It depends on what's going on in your life and circumstances. So I want people to always focus on what's going on right now and what do they anticipate happening in the next year. Beyond that, re-examine it, because at least in New York, you can change these worlds every year. That's something we'll go into a little bit more later when you hear about you might not be able to get certain things. New York is one of the 4 states where we have more protections than the others.
So when you talk about, can you expand on that a little bit, Stuart? So when we talk about where we are right now, what specifically are we talking about? What diagnoses we have, what treatments we need, how healthy we are, what prescriptions we take? What are we
Yeah.
looking at when you're
Yeah.
talking to somebody?
Some people, very important to them to have the greatest access to the most range of providers, meaning doctors, facilities, hospitals, and also the least trouble getting things approved, tests, procedures, etc. Original Medicare with a supplement gives you that flexibility and a national network, very low level of hassle in your life. Medicare Advantage is the one that advertises a lot on television, and there's many companies involved. Medicare Advantage have individual insurance companies that are taking the place of original Medicare, the federal government. So I always have to point out to people, this is something to consider, when you see an ad on TV and this program sounds great and there's a 0 monthly premium, I say, how do they pay for all this? Federal government gives them a lump sum of money. You might say $1,000 a month on your behalf to provide these services. So the Medicare Advantage plans can be very advantageous to some people if they don't have certain conditions currently, they're not a high utilizer of certain services, and most importantly, all of their important providers are in that network. So if someone's going on original Medicare with a supplement, I'm not too concerned about looking up to see if their doctors accept it, because just 98% of the doctors across the country probably do. When someone goes into a Medicare Advantage plan, it's our responsibility to actually check and work with this client to make sure their doctors participate in the network. And of course, their drugs are covered by the plan. So that's important. Sometimes that changes, and perhaps their medical needs change in the future, or their doctors no longer participate in the network, and guaranteed everybody could change to a different Medicare Advantage plan this time of year, the next year. And sometimes there's even other opportunities to make changes. We call them special enrollment periods. So, so that's how we decide. And you really have to find out what's more comfortable for the client. And, you know, I would say that we have to really do our homework with the Medicare Advantage plans. And I guess the last thing I would say is, people ask me, do people like Medicare Advantage plans? I say my clients really like their Medicare Advantage plans until they don't. So that's where it becomes very important for them to have a communication with us. Things are going great. 4, 5 years, things are going great. Something changes. We're all seeing now one particular company has a popular plan and they withdrew it right at the end of this year. So I'm getting calls about that plan. What you were saying about changing, here's the biggest advertisement I'll tell everybody is, all of us who are on either a prescription plan or a Medicare Advantage plan will get a letter in October, around October 1st, called the ANOC, Annual Notice of Changes. I tell everybody, open that letter. But then I talk to people and I say, did you open the letter? And they go, yeah, I kind of saw it, I just tossed it. Open that letter, because if you had that certain plan I just mentioned, I'm getting a lot of calls. People did open the letter and they said they weren't my clients in this case, on any of those plans. But I've been getting calls. I just saw my plan is ending at December 31st. I have to find a new plan. So, so that happens. So that's what I would say. Everybody should open the letter.
Absolutely. And thank you for that. And the thing is, I think if I'm accurate when I have clients that I refer to all of you, is to know that information about your doctors, who your doctors are, if you really want to keep them, what your prescriptions are. All of those things are truly important so that brokers can really find out what's the best fit for you based on your needs. So we can all prepare ourselves that way. Now, we talked a little bit Al, about, when we get Medicare, we said 65. Another question that I get, two questions that I get pretty often are, what if I am working currently? I'm 65 right now, and I'm working currently. Do I have to do something to get Medicare, Al?
Okay, that's a question that I get every week, multiple times a week from people that are turning 65, people that are changing jobs or whatever. And the answer is that don't listen to anybody but a licensed broker because there's so much disinformation about out there. There's a couple of different situations. One is that you're working and you're happy on your plan and you're not paying a lot out of pocket because your employer is funding most of the premium for you, and you're worried about, well, do I have to go on part A? Do I have to go on part B? The short answer is that no, you don't have to do either. You can stay on your employer plan. You can enroll in Part A, and I tell most people to do that because it's free, right? Unless, and this is where you start to get down into the weeds a little bit, if you're working for an employer with less than 20 employees, then you need to go to Medicare and you need to get Part A and B. And further, if you're going to stay with your employer plan and you have a health savings account, you can enroll in Part A because otherwise the IRS thinks that you're double dipping. So you just bypass Part A, stay on your employer plan, and enroll in A and B when you finally retire. Okay. But people that want to leave their employer plan, and the way they find that out is that in my world, I do an analysis for them. I understand the small group market and the large group market, as I'm sure Stuart and Jen do, how it works and what's good and what's bad. So I can get a copy of their plan design. I can compare it from a coverage standpoint to what's available on Medicare. It's easy enough to compare it from a cost standpoint. And then, mindset comes into it a little bit too, because if it's close, well, which way do I want to go? Do I want to stay on my employer plan as long as I can, or do I just want to get it over with and go on to Medicare? So there's all kinds of situations. But if they decide that they want to get off of their employer plan and they're post 65, people that I would call late retirees, which is a lot of, then they get what's called a special enrollment period, as Stuart alluded to, and the employer world is called a qualifying event. So they can enroll within a certain window into any plan that they want to. And then you have to get into the whole situation of which avenue do they take. Do they go Medicare Advantage, or do they go to a Medigap plan where they have to pay for Part B, the Medigap, and the drug plan. All right. So there's a lot of considerations, and I say what your health like, what's your financial situation, and what's your mindset.
So I think all three of those are excellent thoughts. And I think what it boils down to is, if you're about to turn 65, maybe 3 months, 6 months, what have you, call a broker, a Medicare broker, so they can walk you through
if I
it.
can add to that. Yeah, absolutely. They should call us. I get people that call me, and then we have a communication, and it might go on for 5 years till finally they say, I'm retiring now, I'm 70.
Yes, that's
right?
true.
It takes them a while, but two things I do encourage them to examine. One is they need to make sure their prescription plan has what they call creditable coverage. And they get a letter every year around this time that states whether you had creditable coverage. It means it's as good as or better than Medicare prescription coverage. And the other thing is just proof that you had health coverage through your work, because they will have a late enrollment penalty when they leave, because you might have just left the job, but they really want to see that you've had coverage since you're 65, that there wasn't the gap. So I tell people, keep those letters you get every year, in a folder. And the last thing I run into quite often, I had someone anxious this week, a couple wanting to get off their employer plan. Seemed like a good idea, but I sensed that they were high earners. So I pointed them at the chart of not everybody pays the same premium, and maybe we'll get into that later, for the Medicare Part B. Some people pay a lot more based on their income. So when they added that in, they realized it's not as good a deal for them, and maybe they'll wait a little bit longer to make the change. And they have that luxury to do that. But that could have been a difference of $500 a month that they weren't putting into the equation, when I gave them the chart.
Right, right. And
You
again,
know,
these are the nuances that a broker can go through. We obviously can't go through them all right now,
Yeah.
but it's good to know as a resource where to go to get the questions answered. One thing that has come up over and over again, and I get it all the time, is besides open enrollment, Jane, if you could answer this, what are these special enrollment periods? Can you boil that down for us?
Yeah, I mean, there's several different ways to kind of navigate around that, but we do have the annual open enrollment as we're discussing, which is now until December 7th. Then we have what is called the open enrollment, which is from January 1 until March 31. During that time, you can make one switch. And it's not the same as the annual open enrollment where you could make 40 switches and whatever is on December 7th is what stick. You can only make one switch during the January to March time. And then, there are other, as Stuart said, there are other times, like if you move, especially if you move out of state, you must change your drug plan. Sometimes if you're moving within different counties, that would, bring up a special enrollment time, but you have to, check with somebody, an agent who can let you know for sure. Because, for example, if you go, I have one client now who had just moved, but in the middle of all that, his wife wants to take Social Security and all of this. So it was like, all right, how do we keep the New York address and then change to the Florida address? And when do we do it? And all of that. Well, if the drug plan gets wind that it's more than 6 months or 6 weeks sometimes, or they are Social Security has already been contacted that they moved, they'll drop them. So, it's kind of a slippery slope. You have to work with somebody who knows how to navigate what's going on so that, they don't lose their drug coverage just because they moved. The other times that we have is special enrollment periods is we've had it actually since COVID, the FEMA, which is the federal emergency. We've had COVID, we've had monkeypox, we've had you name it. We've had storms, all kinds of things, and gun violence, and they're ongoing. And that gives us an opportunity as well to move somebody if they need to get out of the plan that they're in. So those would be basically the special enrollment times. If we don't have a FEMA, you just can't automatically move somebody because that, is just a special situation. The only other situation, which I don't know whether we want to get into it, but EPIC, which is the elderly pharmaceutical plan it's set up by New York State. There's basically no charge to get in. There are income limits. And it's set up for prescriptions. And if you are basically, in a position where I always say to people, well, it's like having a lotto ticket or a get out of jail card in your pocket, So if they're members of EPIC, and suddenly something is going on in their life and they really need, let's say if they're on a Medicare Advantage and they need to go and get something that's a little bit more comprehensive, we can use the Epic card to make that switch one time in a year. So that's another option that I usually try to make sure as many people as possible sign up for it. There's no charge. As long as you qualify in the income limit, it's always good to have in case it's as an emergency.
I can jump in with
Yes,
two
please.
others that come up for me a lot. The Epic definitely comes in handy, and it's not hard to get it as long as you meet the income limit. But two others, well, obviously when I leave employer group coverage, that is a special enrollment period.
Right.
But the other one that, we know we've had it many times and it's very useful is someone might have been very happy with the Medicare Advantage plan, but now they're in a skilled nursing facility.
Yeah.
And the Medicare Advantage plan may be imposing certain limits on them. And they say, gee, I wish I could get out of this and go back to original Medicare. Well, being in or leaving, either entering or leaving a skilled nursing facility is a special enrollment period.
Right.
So if I get someone who's in a skilled nursing facility and the insurance company says, you know what, you could go home now. It's time for you to go. They haven't examined the patient, but they said our algorithms told us 14 days seems like a good number for your diagnosis. So, but your doctors and the facility says, no, they need more time. On the first of the month, we can get them back on original Medicare using that special enrollment period. It's just that they're in the skilled nursing facility. So that's been very helpful.
We use that one a lot, right?
Yeah.
Yeah.
I think with all of us.
Usually, though, the skilled nursing facility starts it. They're the ones that, there's a lot of times you don't know that your client is there at a skilled nursing. And, and then the client will call you and they're going, well, they're trying to move me. I'm going, well, what's going on? So, yeah, I mean, sometimes you're the last one to find out that plan has changed.
Well,
so that's for you guys. On my end, I'm
some
the one who
facilities will
out.
get involved, and others, I've actually gotten calls from facilities because they know it's possible, but they don't have the capacity to get involved.
Yeah, and so again, what I was saying is, in my capacity, I think, Jane, you were talking about brokers because that makes sense, right? You wouldn't know, but in my capacity as a patient advocate, I found out, make sure that the move goes nicely, because you're right. Some of the skilled nursing facilities will take it upon themselves, but people get nervous because they're like, wait, that's how do they know, what am I supposed to be doing, and how will this change, and what about when I get home, and how will I pay for this, and those kinds of things once they change to a different insurance. So I find out about it, and so I help to facilitate the process often with you all. So the other thing that I get a lot is, and I think you have all come across, is when there's married couples, right? And they think that they are one, as they are maybe in their lives, but as far as Medicare is concerned, if they're both receiving Medicare, they are two different people. So can you talk to us a little bit about that, Stuart?
Yeah, that's something if you take for granted people know what we know, you'll miss that conversation point, because most couples have always, one was the subscriber and the other was just the dependent, and they were tagging along, with the other person. So I really have to emphasize that to people, that in the world of Medicare, you're two individuals. Each one of you gets to pick your own plans. You could actually, in many cases, they do pick the same plans because, they think alike or something, but
But
right?
they think they have to.
But what I try to emphasize to them is one of you might have a lot of needs, medically speaking, and the other never even goes to doctors. You might have very different medical needs. So I really have to talk to each one of you individually about your current needs. And one might be going into a Medicare Advantage plan. The other might say that's unacceptable to me. I need the other, original Medicare. And so it's good in that sense, of the flexibility.
Yeah,
Uh,
absolutely.
yeah.
We've saved people a lot of money who had, again, just like your example, I've had clients that one spouse, again, their medical needs were quite substantial, and the other spouse, it was not. And they were paying as if they were both had the high medical need. And so then to resolve that, really saved them money that they really needed.
Right.
You know,
And I had
another thing, I'm sorry. Go ahead, Jen.
That's right. I just had somebody yesterday who we've been talking back and forth, and it's a similar situation in that the employee is having her husband tag along. But when they were looking at the deductibles and what they were paying, et cetera, they're going, maybe we should have one of us get out. And that's what they decided to do. He ended up, leaving the employer coverage because of financial situations. It was costing them a tremendous amount to stay in the employer plan, whereas if they got out, it was much less.
Yes, and the other thing that comes into play sometimes, and you wouldn't think it would, but are dependents. So somebody will come to you with employer that's on employer coverage. Um, say that the wife is the one that's getting the insurance, the husband's on, and the husband wants to turn 65 and get off the plan. Well, and they have a dependent that's under 65, I mean under 26 or 29 or whatever the limit is on their plan, and they have to account for that. Well, if the insured stays on the company plan, that's fine. But if the insured comes off the company plan because he or she is the one that's turned 65, they now have to scramble to go out and get coverage for until the wife or husband returns 65. The kid goes out and gets a job. Imagine that, or something like that. So this becomes, I can't imagine, I can't believe how many times that comes up with people.
Yeah.
I guess people are having babies late, so.
Well, sometimes I have somebody waiting, like the subscriber will actually wait to drop off the plan till exactly 18 months before the spouse is Medicare age, so they can
right
for 18 months.
They have to get into the COBRA window, right?
So a lot of strategizing can go into this.
Yeah, definitely.
And in terms of that, since you just mentioned it, COBRA, tell us, Al, if you can, about that, because I know that some people get confused in regard to COBRA and Medicare and how that might play into it.
Yeah, and it's very, very technical. But the long and the short of it is in New York, and correct me if I'm wrong, Stuart, for medical, people can COBRA for up to 36 months.
Well, New York, it's not, they don't call it COBRA, we call it state continuation. So it's a different rule. It emulates COBRA, but it could be 36 months. That's assuming you have a small group, meaning a fully insured group under 100 lives.
Right.
So then again, I always have to ask, because there are some smaller groups that are subject to federal COBRA rules. So you really have to be sure of their plan.
Yeah, so it gets a little...
The answer is it's going to be 18 or 36, but many people wouldn't know until you really dig a little deeper about their plan.
Right. So with COBRA, everybody really needs something to understand. If they go onto COBRA is going to pay secondary to Medicare. So if you think that if you're 65 and Medicare eligible, and you think that your COBRA is going to be your primary insurance, you could end up paying 80% of the claim while Medicare pays 20% of the claim. It's called the COBRA trap. And you need to, and it's so situational that you have to really research it and figure out, again, what is the length of COBRA? What's the situation with your employer? Some employers will pay employees COBRA, and that's great. But if it's really COBRA, then it's secondary insurance. It's not primary insurance. So,
Al, would you agree that the trap is an employee might have turned 65, had Part A Medicare only, Now they leave employment at a later age, 67 perhaps. They only have Part A, but they figure I'll just take Cobra for 18 months and life will continue as it did before I left employment. The trap is they were okay with Part A only while they were an active employee. When you're a retiree, they must add the Part B right away.
Exactly. Otherwise, they don't have a primary payer. Right.
Otherwise, they have a big, could be. I had a client a couple of years ago. Somebody called me. They weren't my client, but they were facing $180,000 worth of chemotherapy bills because they did that thing I just said.
Yep.
Right.
Yep.
Right.
I totally agree with
that. Are they also fined? Are people fined because they didn't get Part B coverage? Is there also a fine in that besides paying more for your medical bills?
Not really a fine.
Okay.
But when you leave active employment, once you leave the active employment, you have an 8-month special enrollment period. So if you waited longer than 8 months and wanted to add the Part B, there was a rule that you could only do it a certain time of year, in the first 3 months of the year, and it would go into effect in July. That rule changed last year, so now it's a little more flexible. But still, you have to be careful about, I would recommend adding the Part B. I'm not an active employee anymore. Add the Part B ASAP.
Okay.
Because
That's
you're
good words to live by.
Multiple
totally agree. Yeah.
But that actually is being, by the way, it's being lobbied right now. I'm a member. I don't know if my colleagues are members of what was called NAHU. Now it's NABIP. It's our association, National Association of Health Underwriters. And we've been lobbying to make COBRA considered credible coverage, treated just like active employer coverage, because there really is no difference.
Yeah,
to
everybody else has it, it's the same.
So if you want to keep your coverage for 18 months, that should be your choice. So we have been lobbying to change that law because it's kind of just onerous,
Yeah. So now let's talk about the changes, because there's lots of changes going on. So not that we can go into every single one, but what are some big changes that you're seeing? Let's just go one by one. Jane, what are you seeing for 2024 that people should know about?
If you have friends, family, or anybody that you're talking to that is on an Empire or Emblem plan, they need to reach out and make sure that that plan is still going to be in place for January, because those two carriers are dropping a substantial number of plans.
Okay.
There are changes with the drug plans in their premium. Many of them have just about doubled the premium. So people are very much in shock because they figure, I'm paying enough for the drugs. Why do I have to pay more for the premium? So, I mean, those are two things. I don't want to take everybody's steam. They're going, they're increasing B, So does somebody else want to take some of the other things that are changing?
Alice Stewart, do you want to add to any of those?
Yeah,
changes?
I'll jump in quickly. There are the normal kind of increases to the Part D deductible, the drug plan deductibles from 505 maximum to 545. I think there's less plans this year with zero deductible, and those that have zero deductible are uber expensive. So there's one plan that I had a lot of people on that went from $68 a month to $120 a month. And not only that, but they added a $200 deductible where there was no deductible prior. So yeah, there's a lot of price increases going on. There is
Al, can you describe what a deductible is? A lot of people don't know.
So a deductible is an amount that you pay before your insurance kicks in. All right. So if you have when you have a drug plan, your drugs are arranged in tiers. Tier 1, the cheapest; tier 5 or 6, the highest. Not all drugs are subject to a deductible, but with most plans, if you have a tier 3 drug, it probably costs several $100s, and you're going to have to pay for 100% towards that drug before the insurance company kicks in. Once you clear your deductible, then you move into a next payment phase where you, in most cases, you're paying a copay or some level of co-insurance. All right, and it goes on from there. But one of the things that's happened is that, and it's going to continue to happen because of the Inflation Reduction Act, is that the out of pocket for some of these, for people that have expensive drugs, is being reduced. Next year or in 2025 it's going to be 2,000. All right, but this year what they did was they eliminated the 5% co-insurance in the catastrophic payment phase, and that's a whole seminar right there to talk about payment phases and so on. But I'll give you a quick example. I have a client that is taking Pomalyst, and it's uber expensive. This year it's going to be a lot less.
Got it.
Okay.
Good. We like a lot less anyway. What? Any other things to add, Stuart?
No, I think everybody covered. You could say that the drug plans, particularly for the high-end users, the ones that spend $10,000 a year or more right now, the improvements in 2023 and or rather in 2024, and then again in 2025, will be helpful to a small percentage of people, and maybe 8% really are going to be affected. The other 92% of us, guess what? We're paying for it. So it's shifting, and that's where we're seeing costs going. So I think that's there's good and bad to this, but it does make sense for people to take a look. Everybody was saying about plans going up more expensive. There's actually one plan I think was the most popular plan in 2023, and the premium was only $11 for that plan, and it's going down to $3.70. I wish it actually did not go down, because I'm getting dozens of phone calls like, what's wrong with this plan? It went down. So it's turning out, as we're looking at it, that plan is still okay for those people.
Yeah.
It went down in cost. But the one significant change, that's why you really need to look at these things, is tier 3 drugs typically had a copay. A copay is a flat amount. Let's say $40-something you would pay for your drug. That drug might have been a $400 drug, and you're paying $42. Now that those drugs on that plan, you're going to pay a percentage, 25% or whatever, so your cost might go up. But most of the people who went on that plan originally were the people who use lower tier drugs. So for them, the plan will be fine, and they'll be able to adjust. They take a look, and then they auto renew. But at least they took a look at it.
Yes.
And that plan had a very good formulary to start with.
It's going to continue to be a very popular plan again next year for some.
Yeah, the
Two
problem
of the
is
other
you never know.
changes.
I'm sorry.
What's that?
I said the problem when people ask about what drug plan I should be on, I ask them, well, what drug are you going to be on? I know what you're on now. What are you going to go on in the future? And so I don't know. Well, exactly.
Yeah.
So you have to play the game. Are you going to go on the least expensive plan and kind of roll the dice a little bit, knowing that you can change either during the year with a SEP or at least during open enrollment, or are you going to buy into a more expensive plan and pay a lot of money, just in case?
There's not a strong correlation between monthly premium and better plan. There's no clear, because many people ask me, I don't care what the cost is. I want the best plan. And my answer is what I just said, no strong correlation. You really have to look at your particular drugs and figure out which is the best match for you, because it's not always the most expensive plan. Beyond that, and this is something we were all sharing, and it's a concern to us, is the insurance companies can change their formulary. Like every quarter, they can change their formulary and say this drug is not going to be covered anymore, or it's going to change to a different tier. They're allowed to do that.
Right.
Most of us are not allowed to change our drug plan as easily as they can change formularies. And I get those calls during the year. All of a sudden, the drug is not going to be covered, and it becomes a little challenging. They may be able to appeal it and get it covered, or we might use one of those special enrollment periods and actually change their drug plan mid-year occasionally. But we as brokers have to tell people, whatever advice I'm giving you is based on what they're doing right now, this plan. And if the plan changes, we didn't anticipate that. So that's
Right.
very, I don't know about you, Jane and Al, I find that frustrating.
No,
When
it's terrible.
insurance company change the rules of the game halfway through the
Yeah.
year. Not fair.
But now, managing expectations and making people aware, like you are right now, that these things could happen, help us at least to make decisions with eyes open.
And the
So-
main thing I would say is when something changes, don't just sit and suffer in silence. So when I meet with my clients, I tell them, first of all, when something happens, call us and ask us, and call the insurance company and see if can you appeal it. Because typically, if it's a drug, let's say a new drug you need that's not covered by the plan you enrolled in, they will end up covering it. They'll make a formulary exception for you, not for the hundreds of thousands of people that in the plan, but just for you because you asked nicely and your doctor said they really need this drug.
Yeah, that's always advocate for yourself. There's no harm in asking
Absolutely.
and advocating. Do we have any questions? I don't see anything in chat. Is there any last things, Jane, Al, or Stuart, that you feel like people really need to know?
Well, I just wanted to say that there are two changes as far as the Part B premium. Right now, they've been paying the $164. It's going up to $174.70. And the deductible for Part B, for those of you who are on original Medicare, that would have to pay that, is going up to $240. If this year was $226.
Jane,
So those are
everybody
two.
pays Part B.
Well, yeah, but I mean, the people that see it
Yeah.
are the ones that are on supplements. The Part B deductible, the deductible. I'm not talking about the premium. I'm
Yeah.
talking about the deductible.
Okay.
Right.
Yeah.
Yeah, I think that with regard to some of the people in the lower income area, there's been some changes to low income subsidy or extra help. They've eliminated partial extra help, and you can qualify for full extra help up to 150% of the poverty level. Low income subsidy is a federal program, so they check assets and resources and things like that. But if you think you fall into a low income category, you should contact Social Security and see if you will be able to get, some assistance like that.
Excellent, excellent. Thank you. Stuart, did you have some last thoughts?
Yeah, I would just mention that actually we have in all of our communications, we have to have a legal disclaimer. And they've modified it this year to say the modification is to mention about a SHIP, SHIP, State Health Insurance Program, Assistance Program. They leave out the A, but it's State Health Insurance Assistance Program. And that's part of our legal disclaimer that you could contact them. And I encourage people, like when they have those kinds of questions about what programs they might qualify for, they're people that will help you. You call them up. They're all, you go to that website and they'll find out what programs you might qualify for. The only thing is they're not insurance brokers. So at the end of the day, when they give you advice and point you in the right directions, they'll say you should either go to Medicare.gov and enroll yourself or go to a broker, because they can't do that. But I found they very helpful in figuring out, these programs for people.
Yeah, absolutely. And Stuart was kind enough to give us a resource list that I will try to make available with this recording. And I think Annette had a question.
Yes, so let me get back to my little sheet of notes. I took lots of notes. You guys are great. You talked about the increase in the out-of-pocket on the Part D was going from 505 to 545. So my question is, in addition to that, is there still that donut hole at the back end at the end of the year when people run out of money? Does that still exist? That was one question.
Yes, absolutely, it still exists.
I think you're talking about the catastrophic, I think she's asking about. With the last stage, catastrophic stage?
No, I'm asking about like a person spends 5,000, they put
Right.
1,000 out of pocket, their
Right.
percentage that they paid, but the whole cost was 5,000. And I don't know if these are the numbers because I'm not selling insurance. And then at a certain point, they say, okay, now you have to cover from 5,000 to 6,000. And then it kicks back in a percentage. Maybe it's 7,000. They used to call it the donut hole. Is that still there on
It
Part
is.
D?
It is
So in
definitely
addition,
still there.
okay,
I think the numbers this year are, once you and the plan spend $5,030 for your drugs, including deductible, you enter the donut hole or the coverage gap, and you pay 25% of the retail cost of the drug while you're in the donut hole. All right, so in reality, the expensive drugs where you might have had a $47 copay are once you reach the donut hole might go up to $100, $200 because you're paying 25%. But some of the least expensive drugs, less expensive, a drug that you were paying $10 for might go down to $2.50. So it works both ways, but it really hurts people with the expensive drugs.
is there a cap where you come out of that 25%?
Yes, it's $8,000.
What's that number? Okay.
8,000.
8,000 even?
Right.
Okay. And one other question I think I had, let's see, changing to Medicare plan, you don't need a special enrollment plan. Is that true? If you're changing to Medicare plans, you could do that at any time, right? You don't need a special enrollment plan. Is that still the situation or has that changed?
It's still a situation
Are
in
you
New
talking
York.
about Medigap to Medigap?
I'm talking about you had an Advantage plan before, and now you want to go on to a supplement plan. You didn't used to need to have a special enrollment or anything. You could just go on to supplement, which I understand is now called Medigap. And maybe I don't have that correct. I don't know.
You want to clarify that, Jane, or should I?
Yeah, well, I just think that if you're talking about Medigap to Medigap, yes, you can change. You can't all the time have a time, just automatically say, oh, well, I want to go to a Medicare Advantage plan or vice versa. That you have to have a special enrollment.
I think, Annette, what you have to, in order to have a Medicare supplement, you have to have original Medicare.
Right.
The first thing you do is if you have a Medicare Advantage plan, you can't add a Medicare supplement to a Medicare Advantage plan.
I'm saying if you wanted to
Switch from
change
Medicare Advantage back to original Medicare. Once you have original Medicare, you can add a supplement.
Okay. Let's say I have
But
A
you have
and
to
I
have a
have
special. You have to have a special enrollment period to do what I think you're saying that you want to do.
maybe I didn't make it clear. You have A and B. Let's figure that that's the equation. You have A and B. Now you went out and you got a C Advantage plan, right? Well, in my mind, a C.
Was there.
That usually comes with a D, right?
Yeah.
And then you say, which normally you need either a special enrollment or an annual enrollment, or if you did annual enrollment, then I think you could change again, whatever all those names are. However, what I'm asking is you want to go from C, you picked it, and now it's June, and you decided, hey, I just think it would be better for me because I'm seeing all these bills come in. My situation is changing a little. I haven't been in a nursing home, so I didn't have this big thing that maybe allowed the change. Can I just go into a supplement at any time? I know you can't go backwards, but on the Medigap supplement.
Annette,
No, you need
you
a
can
special
only
enrollment
add a
plan.
supplement when you have original Medicare as your active coverage. When you enroll in a Medicare Advantage plan, you take that red, white, and blue card and put it away in a safe place, because now you don't have original Medicare covering you. You have the Medicare Advantage plan, a private insurance company. So what you need to do is switch back to the original Medicare again, leave the Medicare Advantage plan, go back to the original Medicare. That you either have to do during this period of time or when you have a special enrollment period. And once you've terminated the Medicare Advantage plan and gotten back on original Medicare, now you can add a supplement again.
Yes,
Okay,
I
boy.
think the end
That's
the
in the-
end
In
all
the drug
result
plan. Right.
the end all result is no, Annette, you can't do that anytime. You have to do it in special enrollment.
Right.
Or you could do what Stuart just said, which was a finagling way. It sounded like by
No,
going
that
back
was
to
still
the
in
original
special enrollment.
Medicare.
The way you go back to original Medicare is either during this annual enrollment period, which is now, or if you have a special enrollment period available to you. And a common one is the one I mentioned. I'm in a nursing home, can't access the care I require. I use that special enrollment period to switch back to original Medicare, terminate the Medicare Advantage, and then add a supplement.
Okay, and my other important question that I had was that you said in 2025, out of pocket was going to about $2,000 and something about catastrophic and 5%. I didn't quite get that. But my thing is, when you go for these Medigap plans, they're supposed to be, I think, paying for more things, right? You're paying more money for them. And so if a person was to take that, it might cost them, by buying Part D and the Medigap, maybe, I don't know, depending on where they live, $250 to $300 altogether for Medigap. And so they're doing that to avoid the massive out of pocket that's usually on the Advantage plans, right? Because those plans have like, is it like a lot of them $7,000 out of pocket or something on a regular
Those
Advantage
are the
plan?
max, yeah, you can get to the max out of pocket, but you're not getting there unless you have been constantly, with copays.
I think this comes back these are great questions. I think it comes back to exactly what you need at the time.
Right.
So
And
I
you
think
Well
like
said.
everybody
evaluate it.
said, there's no
Well
one
said,
best
yeah.
plan. It depends on what your needs are and what is important to you. So I think sometimes when we talk about this, it's almost apples to oranges because it depends on what's going on.
I think the
Right, but
bottom
they
line
all
is,
come with
no matter
numbers,
what,
don't they?
the
Don't they all
bottom
come with
line is
numbers?
everybody is an individual. Everybody has individual needs. And when you work with a broker, then they're taking all of that into account to help advise you as to where you're going to have a fit that's going to work for you.
Yeah, and I think that they do have numbers in that. I think you're very right. It's just when you take an extreme number of the most and then like an average, again, it ends up doing apples to oranges. So the individual and talking with the broker, I think, is probably the best way to go, rather than saying an overarching, statement about which is best or which is more
Mhm.
expensive.
Right.
But I think that's all the time we have today. But I love your questions. Thank you so very much for being here. And I want to thank you, the panelists here, the experts in Medicare, for joining us and answering all of these questions. Thank you so much.
Thank you,
Thank you,
Nicole.
everyone.